Diane and Carly to make our presentation tonight. I'm glad you could be here and join us. We would like to begin with a prayer. Especially we remember two people today. You can remember as many as you want, but I'll mention two. Sean Gannon, officer of the Yarmouth Police Department, who was mortally wounded while serving the warrant in Marston's Mills the other day. He'll be buried tomorrow. We keep him and his wife in their prayers. And Dr. Bush, who has made some decisions that some of us will make someday, about how she would choose to pass on to the Lord. You know, we would be struggling with her last gasp right in front of the camera. Now she makes a speech in front of the camera. But Dr. Bush has chosen to do one end of the spectrum of palliative care, that is acupuncture. She's quite old now. And quite struggling. So we keep both of them in our prayers. In the name of the Father, and of the Son, and of the Holy Spirit.
Amen.
Father, we thank you for the gift of life. We thank you also for the gift of eternal life that you offer to us. Help us to be ready for both, to be fully alive while here on earth, and even more alive in the kingdom that is coming. We ask your blessings upon all who gather here tonight, that they enjoy and be enlightened by what they hear. And may our presenter also be wise and good in their teaching. We pray also for those who are here that they go back to their homes tonight, they travel in safety and find comfort in their own home. We make our prayer through Christ our Lord.
Amen.
In the name of the Father, and of the Son, and of the Holy Spirit.
Amen. Okay, welcome everyone. I think you'll be able to hear me, right? Because we're a small group. So, as Father said, my name is Diane McCarthy, and I work for the Archdiocese of Boston as the Parish Education Coordinator for the Initiative for Palliative Care and Advanced Care Planning, which is kind of a mouthful. Prior to coming to the Archdiocese, I worked for 5 years as a chaplain in Catholic long-term care. And doing that work, I had a lot of opportunity to spend with residents and families at meetings, making healthcare decisions, and certainly journeying with people as they, made their journey home to God. So that work that I did really prepared me well to do this education piece. So tonight we're going to do a brief overview of palliative care because I know you've had 2 other educational sessions about that. And then we're going to get into advanced care planning, and then we're going to try to answer the question, why do I have to talk about that? Or why do I have to talk about these things? And as we're going, if you have any questions, feel free. You can interrupt at any time. That won't throw me off, rather than waiting until the end. If you have a question, just go for it. Okay. So I'm going to start off with a case study, and I'm hoping that this case study will illustrate a lot of the characteristics of palliative care. Okay. So you're welcome to read it. I'm just going to summarize it. So in our case study, we're talking about Angela. And when we meet her in this case study is about 15 years ago. And at that time, she was working as a corporate accountant, engaged to be married, and had just bought a house. But then, unfortunately, she was diagnosed with several autoimmune disorders, including lupus, rheumatoid arthritis, scleroderma, and Raynaud's phenomenon. So as a result of her illnesses, Angela was forced to quit her job, and she lost her house. And she recalled feeling very alone, and that no one understood what was happening with her. Because she wasn't diagnosed with one thing, she was diagnosed with 4, and was so sick that she had to quit her job and she lost her house. So she just really felt alone. And as you might imagine, as her physical symptoms worsened, so did her emotional symptoms, and she went into bad depression. But a year ago, her life changed because she discovered palliative care, which is a way for people to live better with serious illness. So what Angela sat down with her palliative care team to talk about what was important to her. How did she want to be treated? How did she want to live in the midst of these illnesses? So from the very first meeting, she felt very comfortable and she didn't find it scary, the conversations or visiting with this team. So it was a good experience for her. So I'll talk just a little bit about palliative care teams. They are comprised of 4 different roles. A medical provider, so I can't just say doctor anymore because nurse practitioners and physician assistants could play that same role. So I'll probably just use the term doctor, but know that it could be any of those 3 people. So doctor, nurse, social worker, and chaplain make up the palliative care team. And they each address their own, specialty, and also can do a little bit of other people's work too, just from the fact that they work as a team. So her team took the time to talk to her about what she wanted and needed in her care. And I'm not sure if any of you have had this experience, but sometimes when I go to my doctor for a physical, my annual physical, sometimes I feel rushed. Like I can't ask all the questions that I want to ask. Or maybe I'll ask a question, but I'd like clarification, but I feel like he's got somebody waiting in the next room, so I'm just gonna, stop talking. But the palliative care team has all kinds of time to talk to you because this is what they do. This is the most important thing that they do, is get to know you, get to know your family, your support system, your illness, what kind of symptoms you're having, your spirituality, all those things. So they literally can...
They're woefully inadequate about that. Just look how many people are addicted because of pain management. And this is another thing, palliative care. That's an awful name for it, by the way, palliative care. It's a terribly derogatory term. But, so maybe something more dynamic.
Right. Well, that's the branding issue. That's the marketing thing. What can we call it that won't scare people off, that will actually draw people in? I don't know.
But I think that's where, if anything's going to change, it has to change in medical school. The old farts out there are not going to change. And they've been trained to fight death as the enemy, and they will fight to the last breath to kill the enemy.
Right.
And that's not going to fit with palliative care.
Right. And it certainly doesn't fit with Catholic teaching. Yeah, that's true. I'm sure in medical, I would hope, I guess I can't say I'm sure, I would hope in medical schools now it's part of the curriculum, but
I believe it is.
But what we're seeing, in the doctors that we see now, that, they haven't.
I think a lot of it being led, what I've seen from the hospitals in town, the state-of-the-art hospitals, is much more encouraging than you see from the outskirts. I think current people, they have teams, they get your family together, they make, they don't make the decision without including people that the sick person wants included. So there's a lot more in those major hospitals, but it's tougher to get out to the outlying areas.
Right. Yeah, the one thing I heard a palliative care physician speak about, I was at a conference on the West Coast, and this gentleman and his agency, and I can't think of the name of it, they do telemedicine. So for the really rural areas, and he said, you think it's a little weird, talking to somebody about serious illness over a monitor. He said, but after a couple of minutes, all of that, you just having a conversation like if they were sitting right in front of you. So telemedicine is going to be a huge way to reach people that don't live in, medical meccas like Boston. So please
One of the issues that
take
you bring
handouts.
up was that, and this is where I am, that I don't want to burden someone else with having to having to enforce decisions that I've made. I think that's an awesome responsibility, but I really, it's one thing to have your spouse do it, or your child do it, but if you don't have a spouse or child, it's hard to just pick someone who's been a friend, even a lifelong friend, or even a new friend.
Volunteers over here.
Yeah.
There you go, Father, you're all set.
Conflict of interest.
Oh. Yeah, I mean, that's true, and that's why, choosing somebody is, in that whole sense of being a burden, but it'd be less burdensome if they know what you want. And also then you'd be assured that you would get treated the way you want.
My point is, they wouldn't necessarily care what I wanted, because I don't know them that well. They're not my child, they're not my spouse, they're not my parent.
Yeah.
So they're like a friend, an acquaintance.
But then you would need to educate them about what you want.
Oh, no, I can tell them, but that,
Yeah. Well,
who knows that they'll carry that out,
well, that's,
Like when the rubber hits the road.
yeah,
It's
yeah,
an awesome responsibility.
It is.
You may not
It
want
is.
to have for some other person.
yeah. It is. But not everybody is going to end up in a situation where the healthcare proxy has to make like a really significant decision, like taking someone off a ventilator or something like that. Like that's certainly a big decision. So, we just hope that you don't end up in that situation for you and your proxy. Okay, anything else? I mean, I'll be here for a few minutes if.
I want to thank Karen Greger, the parish nurse, and Charlie Almanetti, parish council member, for putting on the presentation today. Thank you, Diane.
You're
for being
welcome.
with us. Thank you very much.
You're welcome. My
There are still
pleasure.
refreshments if you like.
Yes,
to leave
there
them.
are. And don't forget to take handouts if you want. And I also have a sheet up here. If you want to get on our mailing list so that you learn about their presentations and take hours at a team meeting if that's necessary. So the team realized, like most of their patients, that Angela didn't just need her physical symptoms managed, but she also needed her emotional and spiritual support as well. And so in doing that, they treat Angela as a whole person, which is something that Catholic healthcare has known from time immemorial, that we're not just a physical being. We have a body, but we also have a spirit, we have a soul, we have emotions, we have relationships, and all of those things need to be addressed in the course of serious illness. So in addition to offering support to Angela, the team also offered support to her family as well. At this point, Angela's mom was her primary contact caregiver, and her mother was struggling with what she was going through, which you might imagine, if any of you are parents, seeing your adult daughter go through this illness and then what happened afterwards with losing her job and everything. So the mom saw a counselor, which helped her, which then in turn helps Angela because now she's not worried about her mother. So that's another benefit of palliative care and having a team. And one thing we like to say too about a palliative care team is I like to describe it as having an extra layer of support. So if you are eligible and access palliative care services, you have this team, but you also still have any other doctors or specialists that you've been dealing with. So you still have your primary care provider, you'd have your cardiologist, oncologist, nephrologist, whatever else you needed. So what you're doing is you're just adding this extra support, these extra 4 people who are looking at you very closely in your case to see how they can help better manage what's going on with you. So Angela's still living with her illnesses. None of the things that she was diagnosed with are curable. But she's starting to get back more into living the way that she was used to. She's because she's feeling better, she can function a little bit more like she did before she was diagnosed. Angela said that palliative care gave her her life back. That she had been diagnosed with those illnesses for 14 years, and she had only been receiving palliative care for the last year, and that was the best that she had ever felt. So it really made a difference in her life. This case study comes from the website getpalliativecare.org, and one of my handouts is a list of resources that I will talk about as we go through the presentation so that you can go back and look and do further education. So now that we've been through that case study, can anybody tell me what are some of the characteristics of palliative care that you got from the case study? What are some of the things that a palliative care team will do that might be different than other health care that you've had in the past? Yes.
You really listen.
They do. They do really listen, and they have the time to. That used to happen to me sometimes when I was working as a chaplain in a nursing home. People would say to me, "Oh, I'm taking up too much of your time," and I would say to them, "No, this is what I do. I'm a listener. You know, you don't have to worry about, I have all the time in the world." And they, and the palliative care team will be able to be good listeners.
They adopt a holistic approach.
Yes, definitely. Holistic approach. So it's not just physical symptoms they're looking at spiritual, emotional, and psychosocial, which means relationship issues. You know, sometimes when people are diagnosed with an illness and they're talking with family members about their plan of care and how they want to be treated, maybe some of the family members don't agree. So the team, the social worker and the chaplain especially, would help get everybody on the same page. Sometimes when someone's diagnosed with a serious illness, it becomes more important to them to to work on relationships that might not be people that they might be estranged from, and they want to rekindle those relationships because they realize that their time might be short. So that's another part of treating the person as a whole person. No one really, not too many people live as an island. Everybody has relationships with family, friends. Okay. Let's see. And there was one other thing that, okay, so the team approach, we talked about that, the 4 different roles, doctor, nurse, social worker, chaplain. And there was one other thing that was pretty important. Is the palliative care team only concerned with the patient? Do they only offer support to the patient? No. They offer support to the family as well. Okay. So those are the major characteristics of palliative care. All right. So here's a definition written by the Center to Advance Palliative Care. Palliative care is also known as palliative medicine, and it's specialized medical care for people living with serious illness. It focuses on providing relief from symptoms and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. So palliative care is a subspecialty of medicine now. As a subspecialty, it's only been in existence for about 20 years. So that's why a lot of people haven't heard about it, or maybe they've heard the term, but they don't quite understand what it is. And that includes healthcare practitioners, not just the public. Because in the grand scheme of medical history, 20 years is not a long time. So it's actually something that has been done before, but they never called it palliative medicine. It's what I got growing up, having a general practitioner as a doctor who, delivered babies, attended people at death, could diagnose a rash like that. That's what a GP would do. They really took care of the whole family. And then we got away from that, and everything seemed to go into specialties. You know, everybody was specializing, so you would have to see a cardiologist for your heart, and a pulmonologist for your lungs, and then they realized, you know, this is crazy. There's way too many people that aren't talking to each other that are trying to take care of somebody. So that's why if serious illness happens, it's good to have a palliative care team.
Can I ask what the difference is between palliative and hospice?
Yep, I think that might be my next slide, actually. Yes, it is. So let me address that in just a minute. I just want to, two other aspects of palliative care are at the bottom of my slide there that I wanted to talk about. So palliative care affirms life and regards dying as a normal process. Okay, I think in our society today, especially being in the greater Boston area that has, you know, all the most unbelievable medical technology in the world, we have started to think or forget that dying is a normal process. There's always that one more thing that we can do. And so to the extent that we can kind of try to remember that, you know, just like birth is a normal process, dying is also a normal process. It's going to happen to all of us. There will be a means of our death. Everyone will have a particular means, whether it's an illness or just old age or whatever it is. Something will stop this body to stop functioning. But of course, as Catholic Christians, we recognize that, God willing, we have eternal life to look forward to. So this is not the end. This is not our permanent home. Palliative care also intends neither to hasten or to postpone death. So hastening death would be something like physician-assisted suicide, euthanasia, voluntary stopping eating and drinking. That would be hastening death, and of course the church doesn't support any of that. But palliative care also tries not to postpone death. So again, we're, you know, just being aware of the finality of our physical being. Okay? Yes?
Just a note regarding, you mentioned the medical aspect of the changes that have occurred over the years, but there's also a theological aspect of that. In the old days, there used to be a family tied to a church and then tied also to a GP on the medical side. So that all came together, you know, when the need was there. However, today, we have so few families attending church as part of the parish, even though they're Catholics. Oftentimes, I know Father's always mentioned that he sometimes doesn't get called till the last day.
Right.
You know, and that's a situation where people don't know what they're missing.
Right.
So
Right.
palliative care, that could be a strong part of palliative care.
Yes,
To put that
absolutely.
together also.
Yep, the spirituality of it, and the ability of the chaplain to help connect people to their faith community, especially if they maybe have been estranged for a little while. Sometimes a person with a chronic illness isn't able to get out and go to church, and then when, you know, they get really sick, they're, I don't know, embarrassed or feel like they can't call, you know, but certainly they can. So the chaplain would be able to maybe help with that reconnection. So yes, you're right. Spirituality is a huge part of palliative care. And even for people who, I mean, as a chaplain, I was trained, I minister to everyone. I personally am Catholic, but I minister to people of all faiths and people of no faith. Because even if you're not associated with a particular religion, everyone has a spirit. And especially when you get diagnosed with a serious illness, that's when you start to ask the big questions, you know, the existential kinds of questions like, you know, what is my life meant? Where am I going? You know, those kinds of things. They don't come up and, you know, if you just have a cold, but you get a serious diagnosis and then you start to think about those things. So it's important that there's a chaplain and a social worker there to address those issues. Okay, so palliative care and hospice, the similarities and the differences, okay? So the main similarity between palliative care and hospice is that it's the same model of care. So hospice teams are the same as palliative care teams: doctor, nurse, social worker, chaplain. Okay? So the model of care is the same. That's the big similarity. But there are two big differences. And the first big difference is in the timing of the care. So palliative care starts at the moment of diagnosis with a serious chronic or life-limiting illness. And by life-limiting, we don't just mean time. So it isn't that you have to have a prognosis of like a year or less or 2 years or less. It's also about how you're able to function. Have you lost function because of your illness? And if so, then you'd be eligible for palliative care to try to figure out a way to help you get some of that function back. And if you can't, then you have the spiritual and emotional support to get used to that new normal. So palliative care starts at the moment of diagnosis. Hospice care doesn't start until a medical team has determined that in all likelihood you have 6 months or less to live. Okay? Now that doesn't mean that you can only stay on hospice for 6 months, because people can start to access hospice services and then maybe at the end of 6 months they're still alive. They will evaluate them, they're still eligible, so they just keep going. But it's also true that sometimes when people start to receive hospice care, because they've got that extra layer of support, they actually start to do better. And they might even graduate, what we would call graduate from hospice. So timing is a big difference. Palliative care early, hospice care very end of life, okay? The other big difference has to do with curative treatments. So when you're accessing palliative care, you can also access any curative treatment that's available to you. So chemotherapy, radiation, surgery, dialysis, anything that makes sense for your case, you can access. With hospice care, typically, that comes when curative treatments have really stopped working and they're no longer beneficial, so you stop them and then you would start to access hospice. So those are the two big differences. And it's really important that we understand the differences, because I think when sometimes people hear the term palliative care and they aren't really quite sure what it is, but they think it might have something to do with hospice care. And they associate hospice care with immediate death, which it isn't, and so then they avoid palliative care too. So it's really important to know the distinction about the timing. Yes?
When they came to do the first evaluation, they said to me, this can be a year and a half. So we want you and him to understand that this is what we're here for.
Yeah. Yeah.
And so I did hospice 100 years ago. So I knew what it was, but it was good for him to understand that.
Are you speaking of your husband?
Yes.
Yeah, yeah. So you're receiving palliative care now?
No.
No, you're receiving...
No, my husband passed 3 years ago, next week.
Say that again? I'm
My
sorry?
husband passed 3 years ago, next week.
Oh, okay, I'm sorry. So you're talking about care for your husband?
Yes.
You were talking about care for your husband.
Right.
And they did indicate to you that it could go on for a
Yes.
long time?
Yes.
Yeah, right. It can. It can.
Yes.
Yeah.
But when I was working, we had a nun who came in as a resident doctor, and she started a hospice group in the hospital I was working in. It wasn't a religious hospital, we said. Like a hospital, but she started a hospice group there, and that's when I became involved.
I see.
It was a long time before I even met my husband.
Oh, okay, so you've been working or worked in hospice for a long time?
Yeah.
Yeah. That's wonderful. Definitely takes special people to work there.
And it's necessary.
It is necessary. Yep, absolutely. Because we need to journey with people. We don't just, leave them alone. Okay, any questions on that slide about differences and similarities? Nope, okay. Oh, one other thing I should probably say about palliative care too is that palliative care is available to anyone with a serious chronic or life-limiting illness, no matter what their age is or what their illness is. So there is pediatric palliative care. There's also palliative care for various forms of dementia. There is palliative care for cancers and palliative care for long-term illnesses like MS, ALS, things like that. Sometimes I use as an example when I'm speaking, say there's a 25-year-old woman who gets diagnosed with MS. So certainly she's got a long life expectancy. And she will want to start with a palliative care team right when she gets diagnosed, so that as symptoms come and go, then she can get those managed. Then she could go for a long period of time where she doesn't have to see the team because everything's great, and then some new symptoms crop up and then she'll go back. So they'll stick with you throughout the course of your illness.
I have another question for you.
Yeah.
As a course of my volunteer work with healthcare insurance, I noticed that over the past 5 to 6 years, a lot of emphasis has been placed on hospice as far as something that's covered.
Yeah.
And I'm wondering where palliative care is in that.
That's a good question. That's a very good question. So palliative care is covered under most health insurance plans, including Medicare and Medicaid, just like a referral to any specialist would be covered. So you get sent to a cardiologist, that's covered. You get sent to a palliative care team, that's covered. The big difference is that hospice care, once somebody goes on hospice, everything that happens to them is one code. So I'm not an insurance person, but so everything that happens to them is one code, and they're hoping to do the same thing for palliative care. So it just makes it easier for insurance and billing and all that stuff to get it down to one code, but it is covered. Okay. All right, so now we're going to go, we're going to talk about advanced care planning and what that means. Okay, so I have a definition up here from the National Institute on Aging. Advanced care planning involves learning about the types of decisions that might need to be made, considering those decisions ahead of time, and then letting others know about your preferences, often by putting them into an advance directive. So advance directive is an umbrella term for any written and oral, but mostly written communication that you give to others about how you would like to be cared for regarding healthcare in the event that you can't speak for yourself. That's what an advance directive is. It's a general term. So a healthcare proxy form is an advance directive. A living will is an advance directive. Okay? But then we get into, okay, so if you're gonna designate a healthcare proxy, or you're gonna make decisions about how you want to be cared for, this requires that you communicate what you've decided. And sometimes that kind of communication can be difficult. It can be difficult for the person who needs to do the communicating, and can also be difficult for the person who is going to hear it. And so, a lot of times I will hear something like this, but this is really hard to do. I don't want to think or talk about illness or death. And so my rebuttal to that would be, this is a conversation about planning for the future. Think about all the things we plan for in our lives. Why wouldn't we also plan for this? Okay? Ellen Goodman, who the Globe columnist, is the co-founder of the Conversation Project, which is one of the tools that I'll be talking about that you can use to do this kind of planning. And she says that advanced care planning emphasizes having a conversation on values. What matters to you, not what's the matter with you. Okay? So it's your values, it's what's important to you, how you want to be cared for. Because the decisions that you're going to make about how you want to be cared for are going to be based on your values. What's important to you? You're not going to just be talking about your illness. And actually, advanced care planning is really a gift to your loved ones. Because if you haven't had a conversation with them and a healthcare crisis happens, then they're guessing about how you might want to be treated. And then you might end up getting treatment that you don't want. So as difficult as it might be for them to engage in the conversation initially, you do it and they get a sense of what you want, and then it isn't something that you have to revisit constantly. You might revisit if you change your mind about something. But so you talk about it and it's done and everybody knows where they stand, and it will help avoid disagreements between family members at an already stressful time. If, you say, this person is my healthcare proxy and this is what I've told them about. Okay, does that make sense? Yeah, believe me, it's not, I know, I'm not saying it's easy, but it's practical. It really is. Okay, so these are some of the tools for advanced care planning that are in use right now in our community. And I have brought a lot of them with me, and you can feel free to take them when you go home. So we talked about healthcare proxy, which is the same thing as a durable power of attorney for healthcare. Healthcare proxy is a really simple form, and I know Karen has some of these. It's a very simple form where you indicate who you want your proxy to be, and then you also indicate an alternate, and then you need 2 witnesses to sign the form who are neither of those 2 people, and it's done. Doesn't cost you anything. You don't need an attorney to fill out a simple healthcare proxy. You certainly would consider going to an attorney to fill out other advanced planning documents like wills, trusts, those kinds of things. But for a simple healthcare proxy, you don't need a lawyer. Living will. So a living will document is something that you fill out that's a little bit more specific about how you want to be treated. So the healthcare proxy just names someone who will speak for you if you can't speak for yourself. But the living will, you actually write, if I was in this medical scenario, this is what I would want. If I was in this medical scenario, this is what I would want. And you talk about things that are important to you. The living will itself is not legally recognized in the state of Massachusetts, but that's not a reason not to do one, because it certainly would help to communicate your wishes to someone else. Especially if you are feeling a little skittish about having a conversation. Maybe if you wrote things down and gave it to somebody and said, I'd like to have a conversation with you about this, but I thought it might be helpful if you just reviewed, what I'm thinking first, and then we could talk about it. So one of the handouts that I have here is the 5 wishes document. I don't know if any of you have heard of this. Unfortunately, all I can get off the website for the 5 wishes document is something that says sample all over it, because they want you to purchase it. It's not really expensive. If it's $5, I'd be surprised. So this is a type of living will that actually is legally recognized in Massachusetts. And the first wish is to name your healthcare proxy. So who do I want my healthcare proxy to be? Then the second wish talks about the kind of medical treatment you want or don't want. The third wish is about comfort. How comfortable do you want to be? The fourth wish is how I want people to treat me. Are you someone who would like physical contact if you're seriously ill? Do you want someone to hold your hand? Or are you somebody that really, has never been a warm and fuzzy person and you prefer to stay that way, forever? And then the last wish is about what you want your loved ones to know. Some people don't want their loved ones to know everything. I would caution against that. especially if those people could at some point in the future have an opinion about what's going on. It's just better to involve anybody who might have an opinion. It's better to involve them. So that's one of the tools. The other one is the conversation project, and this one too, caring conversations. And because these both have the word conversation in them, they really give you, although the 5 wishes document does the same thing, but they give you a lot of tips on how to have conversations with people who might be reluctant to have a conversation. So either of those are good with, for that. In the caring conversations, this is called the Conversation Starter Kit. So, and the first page is about why talking matters. 90% of people say that talking with their loved ones about end-of-life care is important. Only 27% have actually done it. So, you know, and again, it's because it's not a super easy thing to do. A lot of people, another reason to have conversations is because it's a way to kind of relieve your family of the burden of making decisions for you. So a lot of times people are worried about being a burden on their family. So this is one way to reduce that burden, is by having a conversation. 80% of people say that if seriously ill, they would want to talk to their doctor about their wishes for medical treatment. And only 7% say they've had the conversation with their doctor. So lots of good information in those tools. And then there's this is kind of an unusual advanced care planning tool, but it could work. It's actually a game. It's called a conversation game for living and dying well. And the one that I have is called My Gift of Grace, but the name of the game has changed to Hello. And that's listed on my resource sheet. But I think they thought, you know, they wanted to take out the word grace. They were thinking it sounded too religious, but anyway, it's called Hello. So the game has 47 questions, and you first start by answering, do you have any fears about playing this game? And you do it one-on-one with somebody. And do you have any fears? Or what are your hopes about playing this game? What do you hope will happen if you do this? And then it just asks all kinds of questions that will help reveal what's important to you. Let's see. What activities make you lose track of time? So what kind of activity, if your time were shorter than you had hoped, and you had to, and you might want to make a treatment decision based on how you're going to feel, and you love to, knit or read or whatever, that might factor into your decision making because those activities are important to you. Okay. There was one about, if your doctor believed you had 6 months to live, who would you want them to tell? Name the last thing someone else did to give you comfort. So thinking about what are things that, bring you comfort if you needed comfort. What is more frightening to imagine? Suffering the worst physical pain of your life or not getting a chance to say goodbye to your family? So there's 47 of these questions. Oh, this is the one I like. What are the first 3 words you think of when you hear the word hospice? Say that again?
I'm gonna die.
You're gonna die. Yeah.
That's all you ever thought.
Yeah, I know.
We were never taught to think we're all going to die.
Right. We are easily, an extremely death-denying society.
Yes.
And So to the extent that we can kind of shift our focus away from that, I think that, you know, we will end up making decisions that will give us, you know, better, I hate to use the term quality of life because sometimes that's misused, but better well-being, even in the face of serious illness and even as we face the end of our lives, you know. And hospice is not just about death. This is a, you can tell this isn't very old, this game. Do you want your death to be announced on Facebook? If yes, by whom? So anyway, that's also listed on my resource sheet. If it's something that you think, you know, people that you want to talk to would, you know, if you're a family that likes to play games, you know, maybe the game would be a way to go about it. Okay, so one of the other advanced care planning tools is the MOLST document. Has anybody heard of the MOLST document? Yeah. I'm just going to show it to you and just speak about it very briefly because, so at the beginning when I was talking about what an advanced directive was, the MOLST document is not an advanced directive. This is actually a medical order because a physician or a nurse practitioner or a physician assistant has to sign this form in addition to you signing it. So basically, it stands for Medical Orders for Life-Sustaining Treatment, and it's asking you those questions about things like CPR, artificial ventilation, on the front, on the back, dialysis, artificial nutrition, things like that. This is a form that the Mass Department of Public Health put out in 2013, so it's only been around for about 4 years. And the document is basically, it was developed as a way to capture the result of conversations that had already taken place. It wasn't meant to be like a starting point for conversation. You had already had a conversation and then you're just going to put it down. You know, put down the results and sign it. None of the advanced care planning tools or this that I've talked about are cast in stone. So if your situation changes, you just, you know, tear up the old one, you develop a new one, and make sure that anybody that you had given a copy of the first one to, that you give them a copy of the second one. Because as your health changes, your decisions are going to change about whether or not you want to have them attempt resuscitation, or whether or not you might want to be on a ventilator, short-term, long-term, those kinds of things. So I just wanted to mention it in case you saw it. But these are really only meant to be used for people who are really seriously ill. It's not to be used for someone who's, you know, relatively healthy. This is close to end of life. The one thing that it is good for, that I will say, is that if you had someone at home who was chronically or terminally ill, and they had decided they did not want resuscitation attempted, then you would fill out just the front of this form and the doctor would sign it and it would go on your refrigerator. Because that's where the emergency medical personnel look, and they're trained to look for this form, so that if you had decided you didn't want resuscitation attempted and you were in cardiac arrest, they would just let you go. So that's one thing that it's really good for. Otherwise, it's really not needed until the end of life. Okay, but
long-term care facilities are telling people on admission that they have to do one.
I know.
That's not true.
It's not.
That is not true. You do not have to fill it out to go into a long-term care facility.
Yes, and I just well, in the fall I went to a seminar about the document, and EMS people were there, and people from DPH were there, and there was a palliative care physician and a lawyer. And basically the reason why they had the seminar was because DPH has realized that the form is being misused, and they need to kind of rein people back in and get it to be used in the way that it was intended to be used. It is completely voluntary. There's another form that the state uses, and it's called the Comfort Care Do Not Resuscitate Form, or CC/DNR. And that form only indicates what your choice would be for cardiac resuscitation, okay? Which is, in a lot of cases, really all you need if you're going into a long-term care facility. But for some reason, people mistakenly think that that original form, the DNR form, is no longer valid, and that is not true. And what Karen said is absolutely true. That pink form, the MOST form, is completely voluntary. So if somebody says you have to fill it out, you can tell them, I beg to differ. I do not have to fill it out. If you need my DNR status, we'll fill out the other form only, you know. So, because it's kind of crazy to answer a question about, you know, do you want dialysis when you have no kidney disease? How can I make a decision about whether I would want a feeding tube when I am nowhere near that kind of clinical situation? So, you know, so hopefully they will try, you know, we'll be able to kind of rein it in. But anyway, just remember that it is voluntary. Okay, and then of course the last tool in advanced care planning is you. Because if we don't start to think about what we want, start to have conversations, start to write things down and give them to, you know, our healthcare proxy, our doctor, our family members, then it's not going to happen. We have to get the ball rolling. Okay. So I have a little clip that I want to show you about, this is from the Conversation Project, and it's a little video about how to choose a healthcare proxy, okay? So I'll give you my own personal story, and I hope my son never sees this on cable television. So when you're thinking about who you want your healthcare proxy to be, sometimes the immediate, like, knee-jerk reaction is, oh, I'm gonna ask my husband or my wife, or I'm gonna ask my oldest kid, or I'm gonna, you know, whatever. That's automatically what you think of. What you really need to do is you need to make sure that you pick someone who will be able to carry out your wishes, okay? So when I started working at the Archdiocese, I had to fill out, you know, tons of paperwork, new employee. So one of the things I had to indicate was who would be the beneficiary on my life insurance. So I sent a text message to my 30-year-old son, because, you know, that's how 30-year-olds like to communicate. And I said, hey, Kevin, you know, filling out this form, will you be the beneficiary on my life insurance? And he texts back to me, yeah, Mom, but I don't want to talk about it. Not a good choice for a healthcare proxy. If he can't talk about life insurance, how is he going to be able to say, my mother did not want to stay long-term on a ventilator, please take her off? You know, plus he hates hospitals anyways and anything medical, so he's not a good choice. So,
A conflict of interest.
oh, a conflict of interest? Oh, yes, if he was my beneficiary, that's true. Good point, Father, good point. I never even thought of that. I don't think of my son in those, like, kind of devious ways, but you're right. It's been known to happen. So this is a cute little clip from the Conversation Project about who will speak for you.
Be your healthcare proxy? Like if you need someone to tell the doctor what to? I just go with whatever the doctors say. I wouldn't want to bother them. They're so busy. Doctors know best, right? Be your healthcare proxy? Sure, I'd be happy to. If I'm in town, check out my Instagram pics from Peru. Wish you were here.
Oh, I could never let you go. I can't even throw a plant away. As long as it's got one little green leaf. I'd be like, can't we upload her to the cloud?
Well, heck yeah. I've given this a lot of thought. Let me tell you what decisions you're best off going. You never let them resuscitate. And if they even try to hook you up to one of those breathing machines, never. I got this. I totally got this.
How can you even talk about this?
I can't, okay?
I just can't. Mom, it's not like you're gonna die. No, I can't talk right now.
Oh wait, did I show you that meme from iFunny? The cat and the dishwasher? Oh my gosh, okay. So the cat's like, bleh. And then he's what? Oh wait, sorry, what?
you and I have been through so much together. Here's what we'll do. We'll sit down, we'll get a cup of coffee, and you tell me what matters to you.
Well, it wouldn't be easy. I mean, I'd be sad, but I'd have your back.
I remember when we went through this with Mom, we really spoke for her. So I think I can do that for you. Let's talk about what you would want.
So what were some of the qualities of the people that were shown in that clip that would make them not good healthcare proxies? Say that again?
You're reading lunatics.
Oh, yeah, well, yeah, the one with that was talking about the meme with the cat and the ice cream and everything. Oh, what was that you wanted? Yeah, no, she can't pay attention enough to be a good healthcare proxy. Then there was a guy who was like, yeah, I got this. You never do this, you never do that. Well, it's not about what he wants, it's about what you want. Or the woman, the first woman, who would be afraid to talk to the doctor. Oh, I'll just do what the doctor wants. You know, when you're a healthcare proxy, you really need to be able to, you know, make the patient's wishes known to the healthcare team if it doesn't seem to be going the way the patient wanted. And you have to, I mean, you can, you know, to the point where you could consult with the ethics team at the facility if you really felt they weren't listening to you. So you can't be a wallflower, you know, you have to really be able to speak up. And then, of course, the kid that was emotional, that would be like my son, so no. You know, because Mom, you're not gonna die, right? I mean, no, you know, you're never gonna die. So anyway, just, you know, food for thought about who you might pick. Okay. So these are some of the things that you'll consider when you're doing advanced care planning. So, you know, some of these things you'll want to consider on your own initially, and then other things you'll discuss. Maybe if you're receiving palliative care, you discuss it with your palliative care team, or you discuss it with your family or your loved ones, whoever. So your spiritual and religious needs, Charlie brought that up. Remembering that, you know, the sacrament of the sick is not like it used to be, or not what we thought of it before, that you could only receive it once and you wanted to receive it as you were drawing your last breath so you'd go right to heaven. That's not what sacraments are for the living. Sacraments are, you know, give us grace and strength to deal with what we're dealing with in life. So early and often is what I like to say about the sacrament of the sick. You know, communion, if you're able to receive communion, you know, would you want someone to visit you at home or whatever facility you were in? Catholic funeral mass. I have heard more pastors say when I've given these presentations that they are seeing a decrease in the number of people being brought to church for a funeral mass. So if it's really important to you, make your spiritual and religious needs part of your advanced care planning. Say, this is really important to me, you know. I had a case in the nursing home where I had a woman who was 107 who was completely, like, cognitively intact until she had a stroke that killed her, you know, within, like, say, a week. She was at all of our, when we had mass, rosary, everything. And when she died, her family didn't bring her to church. And I think probably because they figured, well, you know, she's 107, she doesn't have any contemporaries, like, who's going to come, you know, that kind of thing. But, and another factor is, next generation maybe not as faithful or as well churched. And because we're a death-denying society and we want to get everything over with, like, you know, really quick, like, let's just tie this up in a neat bow. We're going to have the wake and the service at the funeral home in one day, because then we don't have to think about this anymore. When really the person who passed was a very faithful member of the church and really should be brought to church for a Catholic funeral. So any baptized Catholic deserves a Catholic funeral. So those are some things you might want to put in there. So your psychosocial or relationship concerns, the things that might be, you might need a little assistance with, repairing relationships or getting people on the same page about your care plan. How comfortable do you want to be? Are you willing to accept pain medication? How can we manage other symptoms? You talk about what an emotional roller coaster it can be to be seriously ill. Some days you have good days, some days you have bad days. When you're feeling good, you're thinking, oh, maybe I'm on a plateau here and it's going to go for a while, and then you stop feeling good, and that can, really drive you crazy. So the proxy decision maker, we already illustrated that, I think, with the video. Where do you want to receive care? You can receive care at home. If you need assisted living, you can receive palliative care or hospice care and assisted living in a long-term nursing facility, or palliative care in the hospital. If you're at a point in your illness where you need to be hospitalized, the team can see you there. What else? You'll talk about hospitalizations and readmissions. So you may have noticed that sometimes when someone with a chronic illness nears the end of their life, they start to go to the hospital more frequently. And it isn't always true that the hospital visit is beneficial. So they go in, they come out, they're back in, they're out, and the hospital isn't really helping them at this point because there's not really much left that can be done. Although you can do a lot at home or wherever you are, in a nursing facility or whatever. You can have oxygen at home, you can have antibiotics, you can have IVs, you can do a lot at home. Also keeping in mind that for someone with dementia, going to the hospital can be a really scary thing. Unless there's someone that can be with them 24/7 that they know and they recognize, a person with dementia is just going to see all these strange faces, and these people, these strangers, are trying to do things to them that they don't want done. So again, might the family make the decision, you know what, no more hospital for mom. Let's just treat her as well as we can at home, because it just doesn't make sense to go to the hospital anymore. You're going to talk about whether or not you want resuscitation attempted. And the answer to that question will differ depending on your situation, your case, your age, other medical issues that you have going on. You're going to talk about curative treatments that you might want to explore, like we discussed earlier, chemo, dialysis, surgery, etc. And then you might also talk about whether or not you'd consider, if you're at this point, if you needed a feeding tube or you wanted to have IV hydration, if you wanted to do that. I'll say that the nutrition and hydration, the feeding tube issue is a really kind of gray area. It's certainly a case-by-case thing. And if you were trying to make a decision about that and you weren't sure if you were adhering to Catholic teaching, that's when you would get help from your pastor or a Catholic chaplain or our healthcare ethicist, MC Sullivan, who you've seen before. That's what she does. She takes consults from people who want to make sure that the healthcare decisions they're making are in line with church teaching.
Question for you, Diane.
Yes.
Is it appropriate to put in your hands care planning documentation that you want to consult with someone regarding being in line with Catholic teachings?
Yep. Yes, you can say that. In your advanced directive, you could say that, and this is something that's in the ethical and religious directives, in that little pamphlet, which is somewhere. The ethical and religious directives for Catholic healthcare services, which I believe you guys have copies of, and if not, it's listed as a reference. You can look it up online. But it says in here that, you know, any decision that you make obviously has to be morally acceptable according to the church. And this brochure can help you with that. But if you still had a question about it, I would definitely consult somebody. So you could say, you know, yes, it's important to me that any healthcare decisions that are made, and you would want to tell your proxy this too, are made in line with Catholic teaching. And make sure your proxy knows that and is on board with it. If your proxy is going to say, like, you know, who cares what the church teaches, then not a good choice for a proxy. You know, they have to be able to do what you want. Okay, so Catholic considerations in advanced care planning. So in order to make informed healthcare decisions for anyone, you know, you need the appropriate medical information that you would get from your team. But for Catholics, we also need to know the applicable church teaching. And so I'm going to talk about some of the sources for church teaching. And so one of them is the ERDs that I just held up, the Ethical and Religious Directives, which is written by the United States Conference of Catholic Bishops. So they are certainly a source of church teaching. Papal statements. So the past three popes, Pope St. John Paul II, Pope Emeritus Benedict, and our current Pope, Pope Francis, all have made statements in support of palliative care. So they would be a source of church teaching. Catholic social teaching and diocesan activities like what we're doing right now. All sources of church teaching on palliative care and advanced care planning. So here's some specifics about how the church supports both these things. So just in this past November of 2017, Pope Francis was addressing the World Medical Association, and he made this statement about palliative care. And even if we know that we cannot always guarantee healing or a cure, we can and must always care for the living without ourselves shortening their life, but also without futilely resisting their death. This approach is reflected in palliative care, which is proving most important in our culture, as it opposes what makes death most terrifying and unwelcome, pain and loneliness. So Pope Francis, you know, mentioned those two things that we talked about way at the beginning, not hastening death, but also not futilely resisting it. Because, you know, as Catholics and our belief in eternal life, what kind of a witness would we be to that dogma if we did, you know, tried to do absolutely everything to, you know, keep breathing when it didn't make sense? I mean, because we're almost saying, like, well, we don't believe in eternal life because we're trying to stay here forever. I mean, certainly, like the Pope said, there's no shortening of life, but there's no futile resistance of it either, of death. And then from the ERDs, this book here, the ERDs in section 3 talks about advanced care planning. And so in Directive 25 it says, each person may identify in advance a representative to make healthcare decisions as his or her surrogate in the event that the person loses the capacity to make healthcare decisions. Decisions by the designated surrogate should be faithful to Catholic moral principles and to the person's intentions and values, which is what we've been saying all along. Okay, so one of the other handouts that I brought is this brochure that is hot off the presses. We've been talking about developing one for a long time, and we just did it. And in this brochure, it gives you little bullet points about palliative care, about advanced care planning, about ways to start conversations with loved ones and healthcare providers. And it also has 3 other papal statements that support palliative care. So you can take one of these. On the back, the part that says about who to contact is blank. So obviously, if for your parish, you would contact Karen for more information. that was something that escaped us in our haste to get the brochures printed. So it's a good thing we only printed a small amount to begin with. So to conclude, I want to just show you another small video clip that kind of sums up, what we've been talking about tonight and why it is important to have these kinds of conversations.
My stepdad's really the man who raised me. He and my mom got married when I was pretty young. I remember him as like a very fiery guy. He's very passionate about everything. My stepdad got sick in the fall of my junior year of college, and he had bladder cancer that they found in his kidney. So my stepfather was really aggressive in treatment, early on, and he and my mom were really optimistic, but there did reach a point where it was clear the chemo wasn't working, and that ultimately this would be the thing that we lost him to. I think he had very specific conversations with his doctor. His doctor seemed to be really tuned in with what he wanted. My mom also took it upon herself, though, to start those conversations with him. So my mom had to kind of make it okay and would say things like, let me tell you what I want if I go first. And then he would say, okay, well, if I go first. So she kind of had to make it okay for him. Ultimately, in the final couple of days, he did end up in the hospital. But we were all there, and we were able to say our goodbyes, and he wasn't in any pain. And we were ready in a way. About 8 months after he passed away, my dad got cancer, and he had lung cancer. But my dad was a very different person than my stepdad, and very private, and would never want to burden other people with what he's going through. So I remember staying with him for 2 days and being like, oh my gosh, he's getting really sick and there's no plan. He was heavily medicated and was still driving himself around. Not safe. He was still working. He also lived in an apartment that had lots of stairs and was growing really weak. I went to a number of his doctor's visits with him, and the doctor knew that he lived alone and knew that he was getting weaker, but that was never a part of the conversation of we talked about the chemo and we talked about the radiation, but we never talked about how are you getting to these doctor's appointments? How are you getting in your apartment? Towards the end of his life, he was in incredible pain. And so we rushed him to the emergency room. And his pain was so bad that they had to give him so much morphine to get over that hump that within 30 minutes he was out. And so there was really no time to say goodbye. What I wish his doctor had understood, and that I wish my dad had understood, but especially his doctors, that the cancer was only a small part of what was actually happening in our lives. We weren't talking about what my dad valued and what a good day looked like for him. My dad's experience is nothing anyone should ever experience. He deserved much better than that. With my stepfather, there was always open dialogue about what was happening, and everyone knew where everyone stood. And most importantly, we knew where Jerry stood. My stepdad's death was honestly pretty awesome. And I know that's a weird thing to say, but it was beautiful. And I feel really privileged to be able to have taken care of him. It's a wonderful thing to take care of somebody who's taking care of you. I want everyone to have the experience that my stepfather had, and to essentially have the care that they want, and to feel like they're in control of that experience.
And that's why it's important to talk. Because it was nice that Kate had that wonderful experience with her stepfather, not so wonderful experience with her dad. For us to hear both stories and to see the the contrast between talking and not talking is really, I think, can be very helpful to us. So that's why it's important to talk. Do you have any questions? My presentation is complete.
There are refreshments if you want to get something before we start asking questions.
Yeah.
Feel free.
Feel free. I'm gonna just. I'll shut that down. I'm sorry?
They're not moving.
Oh, they're not moving. Okay, so questions. No refreshments, questions. Yes.
At the beginning, we were talking about palliative care and everything, and I'm familiar with it. But for someone who isn't, when you go to the hospital and you're going to be admitted to something, and you say, well, what about palliative care? Is it automatically offered to you, or what if they say, we don't really know anything about that? Because I have had an instance with someone else that I was with, that they were not offered. They went, what is that?
Oh.
So I mean, how do you get the word out there that there's other things besides hospitals and doctors?
Right. Well, so that's part of the reason why we're doing this education initiative in the Archdiocese, is because we want to educate our faith community so that they're, more prepared as consumers, as healthcare consumers. And so unfortunately, at this point in time, there really aren't enough palliative care practitioners to go around. But, that whole law of supply and demand, I mean, if we ask for it, and that's something that I didn't mention in my presentation, is that if you're at the doctor's and they don't bring it up, and you think that you would be a candidate for it, you need to ask for it. And sometimes doctors are reluctant to refer you to palliative care for lots of reasons. They don't want you to think that they can sometimes associate palliative care with giving up, and they don't want you to think that they're giving up on you, when really we know, after listening to this, palliative care is not about giving up. So if you're in a hospital, I'll tell you that certainly the Boston hospitals all have palliative care. Even some of the community hospitals have palliative care. And if you're in a hospital that doesn't have it, then you talk to your primary care physician when you get the first opportunity, because they are your most important point of contact. And if they're resistant, even after you kind of push back a little bit, there are home health agencies that used to just do hospice that now do hospice and palliative care. And you can self-refer to an agency if you really think that you would be eligible. Yeah. Did you have a question? Yeah?
I was going to ask Pastor, is it against the Catholic religion or frowned upon to donate your body to a medical school when you die?
Not to my knowledge, no.
No, that's actually in this book. It is not. Let's see. I could have sworn I saw it today, but anyway.
Well, one of the provisos, if you were to donate your body to scientific study, there should be an agreement that for want of a better word, the residue of your body should be treated respectfully and buried or cremated according to the rites of the church.
No,
After they've done it.
I talked with the school and they have to accept you, but you also have to go to a funeral home that's going to take your body there and have arrangements made prior to them accepting the body.
Yes.
In other words, if I get accepted at Tufts Medical,
Right.
Conley Funeral Home in Groton will pick up my body and take it to the school. And when they're done with whatever they are going to use me for,
Sure.
then the Conley Funeral Home will
Right,
take care of it.
that's what I'm saying.
Yeah.
Yes.
Yeah,
As
that's,
opposed to being thrown into the hospital incinerator with a number.
Exactly.
Right. No, that would be important, the disposition of your body after they're done. Yeah,
Yeah, thank you.
yeah.
I
Yes.
think the other thing that always amazes me is how few people we have that attend these things. We put some time into this, and Karen puts a lot of time into it. I appreciate your office does also. But I think that's indicative of the problem with this whole palliative care acceptance thing. I don't think that, people think, well, gee, I only have to go to that seminar, the last couple of years of my life.
Right.
Well, then they fail to realize is you don't know when that's going to be,
Exactly.
And,
Exactly. I mean, anyone over the age of 18
yeah.
can designate a healthcare proxy, which then means that that person should have a conversation with their healthcare proxy about how they want to be treated. I mean, accidents happen. Teenagers think they're invincible, but accidents happen. We just don't know. It's so much better to address the issues when you're healthy.
But how do we communicate that with our parishioners, and how do we get them, what have you seen in your experience is what I'm trying to ask?
So, the most people I've ever presented to is 41, okay? So that's not a lot. And, a lot of times I'll have a small group like this, and I think it's like what you said, is that people think they don't need it. I'm not seriously ill, I don't need it. Somebody at one of my presentations recently said that they thought that palliative care had a whole branding issue, which is true, and I'm not a marketer, so I don't, but because the term, people, in a way, I could see that people they don't know what it is. And then again, they might just associate it with hospice, and then it's like, forget it, So I'm trying to think, when I first started, I had a set of bulletin announcements that I was using. And then I started thinking about it, and I'm like, you know what? I'm gonna change the wording on that, because I think maybe this wording will attract people more. And now I actually have another wording that I'm gonna propose to use, because I just think that, how do you draw people in?
Well, as you go through the experience, please keep us informed.
Oh.
We'll certainly borrow anything you want to give us to make,
Yeah.
make it work.
Definitely. I will, I would do that. Because, obviously, the initiative was started by the Cardinal. He literally wants to educate our whole faith community. And I do feel that, so you people are here, and then, you may talk to people, and it's kind of like that old Clairol commercial, and she'll tell two friends, and she'll tell two friends, and then hopefully we'll, really get the word out there. And we can always, come back. Happy to
There are
come back.
groups that would present this to hospitals that are not involved yet. If it isn't, I can't speak, but if it isn't, at the Shore of Jordan, if the palliative care isn't set up there,
Yeah.
is there a group of professionals that could conference with them to help put it into practice there?
Yeah, they're doing all kinds of things in the Boston area to educate healthcare providers about palliative care. Because, think when my primary care was in medical school, they weren't teaching palliative care. They weren't teaching how to have good serious illness conversations, which is why a lot of doctors don't bring this stuff up, because they don't want to talk about it. Whereas palliative care teams are really well-versed in how to have a serious illness conversation. So Harvard and Dana-Farber and there's a bunch of people that are offering education for medical providers about palliative care, about serious illness conversation, and so that stuff is available. It's just, getting them to it.
I personally think we should probably consider planting the seed in pre-Cana, planting the seed in confirmation classes. Just plant the seed. You know,
Yeah.
This is something you might want to think about.
Yep.
Get a little older and start making responsible decisions as an adult.
Well, certainly when someone is considering getting married, that, you know, at those like kind of touch points in your life, those are good times to consider advanced care planning, certainly. So this, you know, that would be a good thing to mention.
I
Yeah.
think at the Jordan, it's palliative care is covered under the Cranberry Hospice group.
That's probably true, yeah, yeah. So they offer both. They offer palliative care and they offer hospice care. Again, that might scare people a little bit if they don't really quite understand what hospice is, you know, like, oh, but they are offering both. Because they realize that the thing is, we're all living longer, right? It used to be that our life expectancy was so much shorter, but as we live longer, chances of us being diagnosed with a serious illness are going to increase. And then we have a lot of great medicines and technology to even help us live with that serious illness. So how can we live better? That's why we need palliative care.
This seems to be an educational problem in the medical profession, and it should be treated in medical school.
Yes.